Welcome to Anesthesia, Pain Medicine, and Intensive Care Education, that is API's foundation. And today I'm going to talk about pacemaker and ICD, some basics, and the newer guidelines which has come up. So first we're going to talk about some universal intraoperative precautions. Then the first one is that if possible, avoid monopolar diathermy. Bipolar diathermy can be safely used. Well, if you want to use monopolar diathermy, in that case, it should be used in short bursts, that is less than 5 seconds. It's important that there is external defibrillator equipment available in close hand within the theater or theater complex. ECG monitoring is desirable. That is for anesthesia, that's 100%. But if it is for sedation or in the ward, then in that case, if the patient is alert and awake, continuous monitoring of clinical signs is fine, and just a pulse oximeter will be enough. A clinical magnet, this is separate to any magnet. It is provided by the companies, pacemaker companies, should be available for any patient who is pacemaker dependent, has an ICD. And that's great if you have a reprogramming facility available, that you have a cardiorespiratory team who is available 24/7. That's fantastic. Now, if electromagnetic interference occurs with the use of diathermy and it is associated with symptomatic loss of pacing function or cardiac output, then ask the surgeons to use short burst of diathermy. Now, if this continues, that is, the patient remains symptomatic, then consider placing a magnet over the device or get the cardiorespiratory team to come and disable the function or change it to asynchronous mode. The next thing you need to know is where is the surgery, where is the location of surgery, and what kind of pacing unit has the patient got. So is the surgery above the umbilicus? Is it below the umbilicus? Is it within 5 centimeters of the pacing unit or away from the pacing unit? Is it a permanent pacemaker? Is it an implantable cardiodefibrillator, that is ICD? Or is it a CRT, that is a cardiac resynchronization therapy device, which can be pacemaker or defibrillator? So which kind of the device do we have? So if the surgery is above the umbilicus and the device is an ICD or CRTD, that in that case, the shock or antitachycardia therapy need to be deactivated during the procedure, that is during the surgery. You need to consider reprogramming of the pacing of the CRT to asynchronous mode only if the patient is totally pacemaker dependent. There is prolonged diathermy used by the surgeon, for example, for cutting, and the surgical site is within the less than 5 centimeter from the pacing device. So liaise with your cardiologist or the cardiorespiratory team for the reprogramming or deactivation. Now, if this is a permanent pacemaker or CRTP and the surgical site is less than 5 centimeters from the device, then you need to reconsider reprogramming to asynchronous mode only if the patient is fully pacemaker dependent or the surgeon is planning to use the cutting diathermy for a long time. So if they don't use short bursts, they are going to use a continuous cutting. And in this case, liaise with your cardiologist and the cardiorespiratory team. Now, if the surgical site is more than 5 centimeters away from the device and the patient just has a permanent pacemaker or CRTP, then there's no need for reprogramming. If any changes happen during the surgery, that is, there is a loss of beat or there's drop in cardiac output or things, then you need to recheck the device in the postoperative period. Now, if the surgery is below the umbilicus and the patient has got an ICD, CRTD, or pacemaker or CRTP, doesn't matter. No need for deactivation or reprogramming at all. So, shock or anti-tachycardia therapy can be deactivated by our cardiorespiratory team, or the cardiologist can do it. Now, if that facility is not available, then you can use a magnet over the device, but it is less reliable. Now, if the device is deactivated or requires deactivation, it should be done just before the patient goes into the theater, and it need to be reprogrammed back as soon as possible. Don't leave it. Now, if the cardiorespiratory team is not available for reprogramming it back, then you need to have the patient admitted to a high dependency or intensive care unit. The next thing is response to magnet. So what happens if you place a magnet over a pacemaker? So if it is a permanent pacemaker and you place the magnet over it, it will convert into asynchronous mode. What is important to know is that what kind of pacemaker it is. Now, each pacemaker company advises where to place the magnet. For some, it can be on the lower part of the device, that is pacemaker unit. In some, it can be over it. Some, it needs to place it above the device, just over the top of the device. This is because it depends where the reed switch is situated within the pacemaker device. Again, for CRTP, you place a magnet, it will convert into asynchronous mode. For the ICD and for the CRTD, it disables the shock or anti-tachycardia therapies, but the pacing or the CRT is unaffected. Hope you found this useful. Follow us up on our Facebook group, that is Global Anaesthesia Society by API's Foundation, for more educational material. Thank you.